Good evening, participants and delegates. Thank you for joining Shield Connect today. So today we came with a new topic, preterm labor, and the topic will be covered by our speaker for the day, Dr. Smriti Uppal. And this educational initiative is sponsored by UTI Flush, OVASHIELD DS, and Embryo Safe. So before we start with the session, let me give a quick introduction of our page, Shield Connect, shieldconnect.in. You can connect this page and you can see there are various sections available. And we already won 5 digital awards for our platform. So the first page is the blog section. So when you click on blogs, you will find all the latest blogs available regarding COVID-19, then GDM, and any infertility related topics written by the eminent speakers and doctors. Then the second section is the webinar section, upcoming and past webinars. So when you click on upcoming webinars, you can find all the webinars that are going to be conducted in future. So when you click on see more, you will able to find a webinar. In the comment section, you can post your queries in the end, so we can have a Q&A session with our speaker for the day. Then we have a past webinar section. You just have to register through email ID and you can find all the webinars that we have conducted in past. So you can also go through the past webinars. Then we have awareness page section where we have PCOS, menopause, GDM, immune booster, COVID-19 and thyroid awareness pages. So if you click on any one page like PCOS awareness page, you will find all the details regarding PCOS by different doctors in different languages like Tamil, Hindi, English, Malayalam. Then similarly, we have a COVID-19 awareness page where you can find blogs and videos related to COVID. And recently, we have also updated GDM awareness page where you can find all the videos and blogs related to GDM. Then we have our leader section page where you can find all the profiles of our key opinion leaders who are connected with Shield Connect. So you can also go through in detail for the profile of our key opinion leaders. Then we have a special day pages. So like if you click on hypertension day, you will find all the videos and blogs related to the hypertension. We also have different days pages like Mother's Day, Safe Motherhood Day, Women's Day. So this is our page Shield Connect, and now let me give introduction of our speaker, Dr. Smriti Uppal. Ma'am has done MBBS, DGO, DNB. I'm his consultant obstetric gynecologist at Sanjeevan Hospital in Dayagani in New Delhi. And the special interest of ma'am is a high risk pregnancy. So we are glad to have you, ma'am, on our platform, and I will hand over the session to you for the topic as a management of preterm labor. Thank you, ma'am, for connecting with us today.
Thank you for your kind introduction. Good evening, friends. Today, we'll be just discussing a few things about preterm labor. It's going to be a sort of revision session for all of us since we keep on encountering such cases in our labor rooms and in our OPDs on day-to-day basis. So, let me just start about the topic. So what's actually a preterm infant? We all know that infants born before 37 completed weeks of gestation, which is known as the term of pregnancy. 37 before 37 weeks, an infant born is known to be preterm. A recently introduced term in this category is the late preterm infant, which includes infants born between 34 and 36 weeks of gestation. Then come the moderately preterm infants born between 32 and 36 weeks of gestation, and those very preterm infants which are born before 32 completed weeks of gestation. So what actually causes preterm birth? A lot of discussion can be done on this topic itself, and it includes both genetic and environmental factors. There are various factors which we all know which lead to preterm labor. They are genetic as well as environmental, a lot more, I would say, environmental these days. And they are definitely a major cause of the neonatal mortality and morbidity in all the countries across the world. So what actually the newborn infant is facing when he or she is coming out preterm is immediately the acute stress of respiratory distress syndrome, possibilities of intraventricular hemorrhage, necrotizing enterocolitis, sepsis, which is a major concern for preterm infants, then patency of ductus arteriosus, and metabolic abnormalities such as hypocalcemia and other nutritional deficiencies. When these patients or our neonates, preterm neonates, come out of these deadly complications, then they are also prone to developing feeding and growth difficulties, infections, apneas, different kinds of neurodevelopmental difficulties, delays in achieving different kinds of milestones, then retinopathy, which is an important complication of preterm infants, which is generally caused because of prolonged and constant use of oxygen for these patients throughout their time in the nurseries and in the NICUs. Then long-term complications, the deadliest among them being the cerebral palsy and the sensory deficits, which incapacitate the baby for the rest of his life. This is just a brief description, graphical description of how various factors are predominant in various gestational ages. So, what are the conditions leading to preterm birth? We have spontaneous conditions and iatrogenic or clinically indicated conditions, what we can say. The spontaneous indications including patients landing in preterm labor due to various causes, patients coming with us with premature preterm rupture of membranes, patients of multiple gestation, which usually in many of the cases land into preterm birth, then patients of cervical incompetence and insufficiency, and the clinically indicated preterm infants where we need to bring the baby out because of some kind of risk to either the mother of the baby or the baby, which presents clinically in the form of preterm labor in 50 to 60% of the patients, or in the form of PPROM in 40 to 50% of the patients. Preterm deliveries where we are doing are in mostly in cases of preeclampsia, uncontrolled hypertension, eclampsia. These patients need to be immediately delivered because if we need to save the life of the mother as well as the baby, imminent delivery becomes very important. Then cases of fetal distress where preterm infants undergoing fetal distress due to some intrauterine causes such as oligohydramnios, severe IUGR, we need to deliver these babies preterm. Abruption, though less common, only 7% of the cases, but yes, in case of sudden abruption of placenta, immediate delivery has to be done irrespective of the duration of pregnancy, and rarely in cases of fetal demise. Risk factors of preterm birth are maternal age less than 18 years or more than 35 years. Yes, very early young primary gravidas as well as elderlies are prone to preterm birth. Then patients of low socioeconomic status, unmarried patients where the pregnancy has been stressful. So psychological factors play a very important role in the risk of preterm births. The known risk factors for preterm birth are a history of previous preterm birth, like we discussed earlier that a history of previous preterm birth due to various causes is again a risk factor for preterm births in future pregnancies, and this risk increases with increase in the number of preterm births in previous pregnancies. Unintended pregnancies like in unmarried women, previous intrauterine or neonatal deaths, then more than 3 spontaneous losses of pregnancy, which could be due to various factors, mostly anatomical factors such as cervical incompetence, which is an important factor for preterm birth. Then the ART pregnancies with various other medical complications such as folic acid deficiency or genital predisposition, obesity, anemia, and low pre-pregnancy weight in the mothers. Then some environmental or social issues such as excess use of tobacco, alcohol, or illicit drug use in pregnancy. Also, various other factors such as systemic diseases in the mother, previous history of premature rupture of membranes. These are important risk factors for preterm birth. Hemorrhages such as abruption, as we discussed earlier, and then multiple pregnancy and overdistension of the uterus in cases of polyhydramnios is always an important factor for which leads to preterm birth. This is just a brief categorization again of the risk factors of the preterm birth: multiple gestation, infection, stress, bleeding, nutrition, excessive physical activity, history of prior preterm birth, and uterine anatomical factors such as the cervical insufficiency, less cervical length, increased uterine contractions, presence of anomalies of the fetus, and overdistension such as in polyhydramnios. What is the recurrence risk of preterm birth? Preterm birth risk rises with increased number of preterm deliveries, as I already discussed. It also rises as the gestational age of the prior preterm deliveries declines. Then most recent birth is more predictive, and the risk is greater in African Americans. So how are we diagnosing the possibility of preterm birth in our patients? A very important and I guess the most vital, the one method of diagnosing the possibility of preterm birth in a patient is transvaginal cervical sonography, where we are measuring the length of the cervix and seeing the condition of the cervix, the dilatation of the os, the effacement of the cervix, etc., to screen and find out patients who are prone to preterm labor, as well as to diagnose these conditions. The TYVU method of studying cervical effacement, as you can see here. This is a graphical representation of relative risk of spontaneous preterm deliveries in less than 35 weeks in relation to the cervical length. As we can see that as the length of the cervix is decreasing, the risk of preterm deliveries is constantly increasing. So what all do we see in the ultrasound? The cervical length is a bell curve. The risk of spontaneous preterm delivery increases as cervical length decreases. This occurs across the entire range of cervical length and not just the less than 10th percentile range. A long cervix carries a low risk of preterm birth, more likely to carry even the twin pregnancies or overdistended uterus to term, whereas a short cervix has a greater risk of preterm birth, and very short cervixes carry a greater risk of early preterm birth, that is even before 32 weeks of gestation. Now, why is the cervix short in these patients? Various factors again: biological variations, that is the anatomical make of the particular cervix, the presence of any kind of inflammatory conditions of the cervix, or prior procedures, surgical procedures, dilatation procedures done on the cervix, or a presence of continuous uterine contractions due to various stimulatory factors. Infection among them is a very common factor which leads to preterm birth. Then presence of stress and activation of maternal fetal hypothalamic pituitary adrenal axis. Presence of any kind of hemorrhage, mostly seen is approximately 20% of cases of abruptio landing into preterm birth, and uterine distension, that is stretching because of polyhydramnios or multiple gestation. Here you can see a very beautiful depiction of the pathways to preterm birth in this flow chart form. As you can see, the activation of maternal fetal hypothalamic axis, presence of stress, and various psychological causes lead to premature onset of physiological initiators of labor. Then presence of inflammation, again increase in the tumor necrosis factor and various interleukins which stimulate the process of labor. Presence of decidual hemorrhage, pathological uterine distension, such as multifetal pregnancies, polyhydramnios, and any uterine abnormalities which cause a mechanical stretch, and oxytocin receptors are activated, prostaglandin synthase is released, and in turn the process of labor starts. Similarly, various cervical changes which cause a release of enzymes known as proteases, which again lead to increase in possibility of preterm birth. Now, risk factors for preterm birth. As we've already gone through this table earlier. Previous preterm births, assisted reproduction, then various socio-economic conditions, various social issues such as smoking, tobacco, drug intake, various uterine anomalies, etc. These are all risk factors for preterm birth. So how do we do the risk screening of these patients? From the history, we can find out the previous condition of labor or the timing of onset of labor in previous pregnancies. As we have already seen that a history of preterm births or a history of more than 3 spontaneous losses is an important risk factor for preterm labor in the present pregnancy. Patients need to be counseled regarding their lifestyle during pregnancy, their psychosocial needs. They have to be motivated to quit smoking, alcohol, and illicit drug intake. This involves a multidisciplinary approach. Then we need to rule out the conditions such as bacterial vaginosis in these patients, and we have to offer screening and treatment to women with symptoms of bacterial vaginosis. These patients also need to undergo the transvaginal cervical length study by ultrasound to see the length of the cervix. Patients having other infections such as recurrent UTIs also need to undergo screening, and these conditions need to be treated promptly so as to prevent the patients from going to preterm labor. If history of preterm birth is there, we recommend a serial transvaginal cervical length screening from 14 to 24 weeks of pregnancy to see the length of the cervix and to see whether the length is decreasing with the increase in period of gestation. In low risk patients of preterm birth, we can do a single transvaginal cervical length measurement during the mid trimester ultrasound. Now coming to the management part, we all know and we all have been using progesterone as an important part of therapy for uterine quiescence, what I would say, and it has been found to reduce the risk of preterm births in women with history of spontaneous preterm births or also with short cervix. It has been found that progesterone has been working in the capacity to prevent preterm births in patients having a short cervix, and we have been putting our patients on progesterone therapy for the same reason. We can consider progesterone therapy for singleton pregnancy from 16 to 24 weeks with a history of prior spontaneous birth, and also in asymptomatic women with incidentally diagnosed short cervix in the second trimester. And progesterone use actually is not much recommended in multiple pregnancies since it has not been found to be very helpful and effective. Cervical cerclage is again an important mode of management in patients who have a history of preterm birth, who have majorly where the reason has been the anatomical conditions of the cervix, such as cervical incompetence, cervical insufficiency, previous due to various previous interventions. There can be a dilatation of the os. So in these cases, cervical cerclage is really helpful. We should consider cervical cerclage for women with a history of one or more prior spontaneous preterm births or second trimester losses related to painless or in some cases painful cervical dilatation in the absence of labor or placental abruption, or in prior cerclage due to painless cervical dilatation in second trimester, or in cases of diagnosed cervical incompetence. Cerclage may also be indicated if the transcervical vaginal length is less than 2.5 centimeters before 24 weeks of pregnancy. So in patients where we are screening the patients because they are at high risk for preterm labor due to various reasons. If the transcervical vaginal length, transvaginal cervical length is found to be less than 2.5 centimeters, we can offer them the treatment by cervical cerclage to prevent preterm labor. Then preterm pre-labor rupture of membranes in a previous pregnancy, patients having a history of that, a history of cervical trauma or surgery which has somehow caused cervical incompetence, and prior spontaneous preterm birth before 34 weeks of gestation. So, what is the rationale to determine risk of birth within the next 7 days? How do we assess that? We assess the maternal and fetal well-being, review the history and risk factors, find out in which category our patient falls, whether the patient is in high risk category or low risk category, and assess for signs and symptoms of preterm labor. How do we do that? We do an internal examination, do the check for the cervical effacement or dilatation, look for contractions, get a history of lower abdominal cramping or back pains, uh, inquire about and check for vaginal secretions such as mucus, blood, or fluid discharge per vagina, and look for regular uterine activity. We need to monitor the vital signs of the patient and do an abdominal palpation to see if the uterus is irritable or already having contractions. A sterile speculum examination to exclude uh, leaking, to assess the cervix and collect a high vaginal swab. Also collect either a vaginal rectal or vaginal perianal swab for group B streptococci and obtain sample for fetal fibronectin test. So fetal monitoring in these cases has to be done by a continuous CTG, which would be best to look for contractions also and to monitor the fetal heart rate. Then maternal laboratory investigations like the high vaginal swab has to be sent, and a midstream urine has to be sent. Transvaginal cervical length. How is it important? The risk of preterm birth increases with a shorter cervical length, we all know. If history of preterm birth is there, we recommend serial transvaginal cervical length screening from 14 to 24 weeks, as I already mentioned. And for patients in the low risk category, we are screening for the cervical length only while we are doing the mid trimester ultrasound of the patient, where we see the cervical length to see whether it is adequate or not. And we consider any kind of intervention such as cervical cerclage which can be offered to the patient if in our mid trimester scan the cervical length is found to be less than 2.5 centimeters. What is the screening test to assess the risk of preterm birth in the next 7 to 14 days? Yes, there is this screening test available, which is the fetal fibronectin testing, and the indications would be between 22 weeks and 37 weeks of gestation with intact membranes and a cervical dilatation less than or equal to 3 centimeter. Patients when examined clinically are found, if we find that cervical dilatation is there or the cervical length is less, then we need to assess this patients for fetal fibronectin levels so as to uh, predict whether these patients are likely to go into preterm labor. Indications for asymptomatic women would be greater than 22 weeks gestation with a history of cervical surgery or trauma, a preterm birth in a previous pregnancy, or a late miscarriage or mid trimester pregnancy loss. The patients need to be admitted and kept under monitoring in these cases if the fetal fibronectin level is greater than 50 nanogram per milliliter, which is a strong predictor of the possibility of the patient going into preterm labor in the coming week. Then presence of cervical dilatation is there if the cervix is dilated, if the cervical changes are progressing over the uh, to next 2 to 4 hours. If the membranes are ruptured and there is evidence of leaking, if we are finding any constant uterine irritability or presence of uterine contractions, the patient needs to be admitted and monitored and administered medication and treatment accordingly. And other maternal or fetal concerns such as other high risk factors if present, along with the possibility of patient going into preterm labor, then the patient needs to be admitted with us. Use clinical judgment and appropriate consultation. Yes, it is important to consider if the patient needs to be transfer, the in utero transfer is indicated, so that the patient can be admitted in a facility where proper NICU facilities are available, and facilities for management of preterm labor are available. Offer analgesia to the patient, administer corticosteroids, because in preterm labor we need to ensure the lung maturity. So 2 doses at least, if possible, of corticosteroid to be administered to the mother. And we need to continuously screen the cervical length by transvaginal sonography. Communicate with the multidisciplinary team so as to be able to manage the patient as well as the neonate promptly. And then obviously discuss the plan with the patient and document everything and take proper consents. Antenatal corticosteroids are found to reduce fetal mortality and morbidity because they are helpful. They have been found to be helpful in preventing the respiratory distress syndrome and enhance lung maturity. Recommended with viable fetuses before 35 weeks of pregnancy, and in especially in patients with maternal diabetes and multiple pregnancies, we can administer the even on the basis of our prediction of the possibility of patient going into preterm labor, or we requiring to terminate the patient terminate the pregnancy in a preterm gestation, we need to administer corticosteroids. Also, if risk of preterm birth persists even 7 days after the initial course of corticosteroids, we can repeat the dose. Now, tocolysis. Tocolysis may delay birth and allow in utero transfer. Corticosteroid, we can buy time for the steroid administration and the completion of action of the steroid, which is 24 to 48 hours. Then we can offer magnesium sulfate to the patient and prevent delay the delivery by approximately 24 hours. Tocolysis is contraindicated in cases where we are suspecting chorioamnionitis or infection in patients of severe preeclampsia, where we need to terminate the pregnancy because more for the maternal indication rather than the fetal indication. If there is presence of lethal fetal anomalies, or there is intrauterine fetal death, then tocolysis is definitely not recommended. And also tocolysis is not recommended in cases of hemorrhagic conditions such as abruption, where the mother is hemodynamically unstable, and in conditions where mother is hemodynamically unstable. Which is the tocolytic of choice? Yes, nifedipine. And I hope all of us have now shifted to use of nifedipine, because it is quite safe and quite an effective tocolytic with very few side effects. It is a calcium channel blocker which relaxes the uterine smooth muscles. And coming to the use of antibiotics, routine administration in threatened preterm with intact membranes is not recommended. And if established preterm labor or imminent risk of preterm birth, we can give a dose of prophylactic antibiotic. And if the membranes are not intact, obviously we need to put the patient on an antibiotic. Look for the signs of chorioamnionitis, that is temperature more than 38 degree, maternal as well as fetal tachycardia, uterine tenderness and with a foul smelling, vaginal discharge. A blood picture study would indicate elevated total counts. If intact or ruptured membranes and signs of chorioamnitis, we do not inhibit labor, as I already discussed. And in fact, we should consider hastening the birth and use broad spectrum antibiotics for this patient. Coming to the use of magnesium sulfate, this has been found to reduce the risk of cerebral palsy and protect gross motor functions in preterm infants. It is recommended between 24 and 30 weeks where birth is expected or planned within 24 hours. This is basically to not as a therapeutic, um, I would say, drug for control or stopping the contractions, but for buying time to administer corticosteroids or for in utero transfer of the patient. Now, what should be the mode of birth in these cases? There are various conditions and recommendations. Singleton pregnancy, cephalic presentation with more than 26 weeks of gestation, we recommend vaginal birth unless cesarean section is indicated for any other reason. Then if it is breech and more than 26 weeks, then if the vaginal birth is imminent and the pelvis is adequate, we can offer vaginal birth, but generally I think all of us are preferring to go for a cesarean section itself. If less than 25 weeks, vertex or breech, cesarean section is only for fetal indications and not generally recommended as per the guidelines. How do we manage the patient after threatened preterm labor? A patient who had an episode of threatened preterm, we have to provide care according to the circumstances. If patient needs continuous monitoring, we need to prolong the admission, and we can discharge the patient if maternal vital signs and the membrane status is intact and there are no contractions and cervical changes I have not been found to be progressive, and also if the fetal fibronectin test results are within the normal limits, and definitely the NST or CTG is good. While discharging, the woman needs to be informed of the sign, how she needs to be educated rather to recognize the signs of preterm labor and immediately report to the hospital whenever she is in doubt. And identify the risk reduction methods. Also, we need to provide instruction about when to seek clinical advice. So with this, we come to the end of the presentation, and there have been various different drugs which have been used for tocolysis, but I think nowadays mostly all of us are using nifedipine. And I would also, from all the listeners, I would welcome their experiences if they would share if they are more comfortable using any other drugs for tocolysis, such as the new drug atosiban. I do not have much experience of using that drug. I would like to invite the listeners to share their experience if they have for tocolysis using atosiban. Thank you.
Thank you, ma'am, for giving all this information regarding preterm labor. So let me check if we have any queries in the comment section. So, ma'am, I have one question that how endometriosis have an impact on preterm birth?
Endometriosis per se, I don't think has any is not a major risk factor, because usually endometriosis is found to be suppressed due to the prolonged hormonal changes induced by pregnancy. In fact, while treating endometriosis also, we are trying to create a pseudo pregnancy like state. So endometriosis per se is not a very important risk factor for preterm birth.
Then, is L-arginine useful as a supplement to prevent preterm birth?
Not L-arginine,
L-arginine.
no. L-arginine is more being used to prevent the occurrence of preeclampsia, and also for eye patients with IUGR. obviously you can say that it cuts down it helps us in cutting down the risk for the clinically indicated preterm deliveries, because if it prevents these conditions like severe IUGR or preeclampsia and pregnancy induced hypertension, if it prevents these conditions, then it definitely is somewhere helping in reducing the percentage of clinically induced preterm births.
Then, ma'am, what will your recommendation on diet to the pregnant women to prevent such preterm conditions? Diet factors.
Dietary factors, all the dietary factors which will prevent any, I would recommend a diet which is rich in fiber with
Mhm.
lots of fluids, so
Yes.
that the abdominal stress is reduced as far as possible in these patients.
So let me check if there is any more questions. So I cannot see any more questions. And thank you, ma'am, for giving all these answers for the questions. And we are glad to have you on our platform, ma'am. And we would like to have more sessions with you on our page, Field Connect.
Right.
Thank you, Delegate, for joining today's session.